Hello everyone, my name is Omar Abdulaziz Ismail, Assistant Lecturer of Restorative and Aesthetic Dentistry. All of you had met some people that change their smile. In some occasion, that makes them shine like the stars. In other occasion, they became very, very ugly, like if they have shapeless appearance. Who judged that? As a dentist, how you say this is perfect smile or this is bad smile? There is hundreds of dentists that make many papers trying to throw the guidelines of aesthetic dentistry. We will discuss today the recent evidence-based aesthetic dentistry guidelines. And also, at the end of the video, we will have a workshop that will allow you to draw and make a planning for perfect smile using DSD or any other smile design application. So let's start. Our lecture title is Smile Design High Performance Planning. I already introduced myself before. All the elements, the database elements that we will discuss, you could find in this group, Tooth Talk Smile Design group in Facebook. We will discuss today the evidence-based aesthetic guidelines that you could use to judge any smile and plan for any perfect smile design. It's divided into the macro facial element and the micro aesthetic dental element. Among them, the shoe analysis, tooth to tooth proportion, or the traditional Colton proportion. And at the end of this video, which is very important, we will have a smile design PowerPoint workshop. Here in Egypt, many people criticize the smile of an actress called Regina. After all of that, we will use these guidelines to judge her smile. Okay, let's start. Beauty is in the eye of the beholder. What does that mean? It means that aesthetic dentistry or any aesthetic guideline is very, very qualitative measurement, different from someone to another. Like someone may find the beauty in the ancient monument, another one will find the beauty in the sea creatures. By the way, these photos I take by my mobile in Sharm el-Sheikh. They give you a cover, you put the mobile in it, became water resistant, and you take this beautiful photo. Or maybe you find the beauty in the canals, like in Europe, or the beautiful Nile here in Egypt. So how we make this qualitative measurement, which is very difficult to follow, and will always different from someone to another, to a quantitative measurement. This fundamental aesthetic standard can help us as clinicians to design and create beauty in quantitative and predictable manner. First thing to do is to make a three-step analysis. First, you identify the problem. Second, visualize the customized solution in 3 dimensions. And at the end, choose appropriate technique to get there. Historically, the diagnostic approach has been led to the structure, then function, biology, and only then to consider aesthetic, which could easily result in a compromised aesthetic outcome and unhappy patient. What we are suggesting to consider is static firstly, which is usually the patient's chief concern, and then studying the structure, function, and biology. By diagnosing cases in this new sequence, we set ourselves up for success, optimizing, communicating from day one, and ensuring that we meet the desires of our patient. Step 2, analyzing to perform a diagnostic workup on the mounted cost that is guided by the information from the aesthetic evaluation form. This allows us to visualize the tooth shape, position, soft tissue harmony, and many other elements. Once the diagnostic workup is done, we then transfer a mock-up into the patient mouth. This offers our patient a preview of the visualized solution, and it's an opportunity for us to gather crucial feedback by listening to the patient opinion. The notes we take in this stage will be conveyed directly to the lab technician, and together with the dentist and patient, the three parties then become empowered team, which is called the communicative triangle information flow. Dr. Peter Dawson once said, if you know where you are and you know where you want to go, getting there is easy. And that's what we are going to do. We begin with the open-ended question. If there is anything you would change about your smile, what would it be? Instead of asking the patient a closed question like, do you like your smile? These kind of questions that give you yes or no answer. We need to make the patient talk to us, to understand his way of thinking. We are guided by the rule 80-20 rule of listening. You should listen to him 80% of your time. You could give him an example, like, do you like your teeth to be straight, white, and perfect? And all teeth are mirror image with very light shape and perfect alignment. You like to picture this actress, Halle Berry. As you could see, I will enlarge the photo. Her teeth is very white, perfect edge, parallel to each other. Other people prefer the clean, healthy, and natural category, like having a natural, maybe slight rotation, some setbacks, yet very natural and beautiful smile. The perfect example for this is Sarah Jessica Parker's smile. As you could see, if I enlarge the photo, there is a little bit shaping here and rotation in this lateral, yet she has a very beautiful smile. And the middle solution, the white and natural teeth. It's midway between the first two options, like Julia Roberts' smile. Her teeth is very white, but there is some rotation. It's not so much perfect, so it's white and natural. All of these are perfect solutions, and you got to make your patient choose. You have to make him participate in your treatment modalities. We'll start with the macrostatic elements. First one is the parallelism between the interpupillary line and the line corresponding to the occlusal plane, which is drawn between the cusp tip of the maxillary canines. Then we will check the facial midline in relation to the maxillary dental midline. As you could see, you could use PowerPoint, draw a line passing through the pupils of the patient. And in such photo, you couldn't make sure that this line is parallel to the occlusal plane. So the patient should smile in order to check the parallelism. Then you check the midline, facial midline, and dental midline. Another element is the nasolabial angle. Typically, you strive nasolabial angle of 90 degrees, and thus an angle of less than 90 degrees means that there is a prominent maxilla. The maxillary anterior restoration should be smaller and less dominant, while an angle greater than 90 degrees means that we have a protruded maxilla. Such occasion, the maxillary anterior restoration could be pulled out. As you could see, the black line is the nasal line. And this is the labial line. We have here an acute angle. So the maxilla is prominent, and we couldn't make it more prominent. This will worsen the aesthetic profile. Another guideline is the Ricketts E-plane. It describes the imaginary line drawn from the tip of our patient nose to the chin. Ideally, the upper lip is 4 mm from the E-plane, and the lower lip is 2 mm away. If the upper lip is greater than 6 mm, that means that this patient have a concave profile. Otherwise, if the lips are on the plane, this means that this patient have a convex profile. To sum up, in nature, a maxillary central incisor can be anywhere from 10 to 11.5 long, and it's appropriate to design the maxillary central incisor toward the larger end of this range for the concave patient, and toward the smaller end of this range for those who are convex. As I just said, concave patient, if the patient lips away from the E-plane more than 6 mm. In the convex profile, patient's lips touch or pass the E-plane. As a rule of thumb, for the convex patient with a high smile line, the length of the maxillary central incisor should not exceed 10.5 mm. We are ready. Another patient. That's the E-plane. The lower lip is touching the E-plane. This is a convex patient. And also, the nasolabial show acute angle less than 90 degrees. That means the maxilla is prominent. Convex patient and profile and maxilla is prominent, you shouldn't exceed the length of the maxillary central incisor more than 10.5 millimeter. If you exceed the maxillary central incisor in such cases more than 10.5 millimeter and use the other end 12.5, you will find a very ugly, prominent, ugly duckling appearance. Another trial is the eye plane. This patient lives even past the eye plane, but his nasolabial angle is 90 degrees. Yet, you shouldn't make such patient induce treatment with his central incisor is long. It will be very prominent and ugly. Tooth exposure at rest. To assess the amount of tooth display at rest, we ask our patient to relax her lips and say, Emma, Emma, and then freeze. Another way, you could ask your patient to breathe from his mouth. You tell your patient to relax and stop breathing from his nose and start to breathe from his mouth. You could detect now the tooth exposure at rest. As a study of Vig and Prondo, they noticed that a woman at age of 30 shows 3.4 millimeter of her maxillary central incisors with the lip at rest, and at 16 years old, at 60 years old of age, the maxillary central incisors are no longer displayed, and even 3 millimeter of her lower incisor display. He notes also that a man shows 1.7 millimeter of the maxillary central incisors at the age of 30. Will decrease the maxillary central incisor display at the age of 60, which is due to loss of muscle tone over time, gravity, and wear of the incisal edges. So for these patients, lengthening the maxillary central incisor will give them a more useful appearance. We are still in the macro aesthetic element. It's very critical, that one, the smile line, either average, high, or low. As you can see, this high midline, high smile line, this is average smile line, that's the low smile line. This high smile line characterized by total exposure of the clinical crown and continuous strip of gingival tissue. The medial smile characterized by greed, 75% or total 100 exposure of the clinical crown and interdental papilla without further stripping of the gingiva. The low smile line characterized by exposure not greater than 75% and no gingival tissue display. These different smile lines dramatically affect the treatment modalities. Another element is the incisal edge relationship with the lower lip. Either it's convex curve like you see in this picture, or straight or reverse. And of course the convex curve is the most aesthetically choice. And then the teeth relationship to the lower lip, touching or not touching or slightly cover. We should also notice how many teeth appear when the patient smiles. 6, 8, 10, or 12. But don't worry, it's too many elements. But at the end of this video, you will understand how to use each element to guide you to the perfect smile for this patient. We should also notice the midline location at the center, or right to the center, or left to the center. And the midline skewing of the lower midline to the upper midline, straight, right, or left. Last macrostatic element is the dentofacial analysis. I mean the buccal corridor. This yellow part. Is it wide, intermediate, or even narrow? The dentofacial analysis. Last one is the phonetics. It makes the patient say S, S, S to notice the lisping, which will guide you that there is a problem in the overjet and overbite of the patient. Or it will make the patient say F, F. When the patient say F, you look at its central incisor. F. Normally, his central incisor should touch the wet and dry line with the lower lip. If it's past the wet and dry line, that means that the patient have a prominent teeth. If it doesn't even touch the wet and dry line, that means that his maxillary incisor is retruded. And that is the end of the macroaesthetic element. We'll start now the microaesthetic element guideline. First one, most important one, is the incisor edge position. Ideally, the edges of maxillary central incisor is at the same line with the canine, and the lateral incisor will be 0.5 to 1 millimeter above this line, but that have been changed. Many users prefer the new smile arc design. At this design, the bottom line of the top teeth makes a curve that exactly matches the curve of the bottom of the lower lip, like you could see here. It's too much, as you could notice from the difference these two images, that new smile arc design is way more aesthetically acceptable than the traditional design. We could achieve that, as you could see from this spike, by making the lateral incisors less half millimeter from the central incisors, and the canine is less 1 millimeter than the lateral incisor. That will make this patient have an arc parallel to his lower lip. The Senate's point. The mucogingival stem is highest at the distal aspect of the maxillary central incisor, approximately 1 millimeter distal to the tooth midline. This is often described as a gull-wing effect. The zenith point of the lateral and the canine, however, should be centered mesiodistally. The ideal ratio between the length and the width of the maxillary incisor is the most critical element. To sum up, I have told you that the nasolabial angle is very important. If it's acute, this is a prominent teeth and you couldn't make it longer. Also, we talk about the E-plane, and in case of convex patient, that means also that this patient have a prominent maxilla, and we prefer the short central incisor in this situation. And many other macroaesthetic elements will lead you to the appropriate length for the maxillary central incisor. And from the length, we will get the perfect width. So if, for instance, this maxillary central incisor is 10 millimeter, or supposed to be 10 millimeter to give this patient the perfect smile, perfect ratio is that its width will be just 8 millimeter or 85. That's the ideal ratio. If the width is 77.5 millimeter, this will give this ugly long teeth appearance. On the other hand, if the length is 9 millimeter, for instance, this will give the patient a square short, which is also ugly appearance. So from the length that we get the perfect width. And from the width of the central, we will get the perfect width for the lateral and canine. Another microaesthetic element is the soft tissue symmetry. As you could see, suppose that the gingival height of the maxillary central and the canine should be at the same level, with that of the lateral being 1 or 1.5 millimeter below this line. This is especially critical in the high smile line patient. But also this is a traditional design. Many authors believe recently that if all the anterior teeth at the same gingival level, this will give much better aesthetically acceptable appearance. The limits of aesthetic acceptability of the gingival symmetry in the aesthetic zone. A is the width of central incisor. The mesodistal dimension of the maxillary central incisor, with only half millimeter difference, could be acceptable between the two centrals. As you know, this is the most critical element of aesthetics. P is the mesiodistal dimension of the lateral. 1 millimeter could be acceptable at this situation. Meaning the right lateral is 7 millimeter. The left lateral, if 6 millimeter, could be not noticed. C is the mesiodistal dimension of the canine. And D is the gingival level of central and canine. It said here that 2 millimeter difference is acceptable in the gingival level symmetry. For my opinion, this could be acceptable only in case of average or low smile line. Nevertheless, in case of high smile line, 2 millimeter difference in the gingival level between the two central is unacceptable at all, because it will be easily noticed. Now, we will discuss another element, the tooth-to-tooth proportion. The latest biometric study from Dr. Stephen Shaw shows that if the central incisor mesiodistal width is x, then the lateral should be measured x minus 2, and the canine should be measured x minus 1. You should notice that x1, x minus 1 is the mesiodistal canine dimension versus the traditional Colton proportion approach, which only according to the mesial half of the canine. The Shaw analysis is much more accurate than the Colton proportion. The axial inclination of the teeth. 6 anterior teeth have their root distally inclined, with the centrals being closest to upright, and the inclination increases as we move distally. This reflects the position of the underlying roots, as no two structures can occupy the same space. The contact area. The contact area between the two centrals starts at 40%. This ratio decreases moving distally. And the contact between the central and the lateral is 30% of the central length. The same here. The contact between the lateral and the canine is 20% of the lateral length. To sum up all this information, the macroaesthetic element is firstly the interpupillary line between the two pupils and the facial midline, the nasolabial angle when you look to the profile of the patient from the nasal border and a tangent to the lip, and the E-plane from a tangent from the most anterior point of the nose and the most anterior point of the chin. The tooth exposure at least. You ask a patient to say Emma, Emma, or to breathe from his mouth. Smile line, an excessive smile, and you noticed you have high, average, or low smile line, and we said how you differentiate between them. Incisal edge relation to lower lip, and how your teeth touching the lower lip. It's by the way the same F test. And how much teeth displayed when you smile and the buccal corridor, wide, narrow, intermediate. And these are the macroaesthetic elements. The microaesthetic element, the incisal edge position, the gingival symmetry, and we discussed the traditional and the new concept of them. The ratio between the central incisors, width and length, which is 85%, tooth to tooth proportional, shoe analysis or golden analysis, axial inclination, the best contact area dimension, and the line angles. How we could use all of these? Firstly, you have to understand the best lens for this central incisor. And you could take that from the nasolabial angle, acute or obtuse, the E-plane, concave or convex patient, tooth exposure at rest, okay, and the smile line. With these criteria help you to the best choice for your central incisor. To be long, 12, 13 millimeter, or just 10 millimeter is enough. After that, from the lens, you get the width. And from the width of the central incisor, you could get the width of the lateral and the width of the canine. Talking is easy. So we'll start now the workshop and show you how to exactly design the smile. Okay. Hello again. We are going to discuss today the Smile Design High Performance Planning workshop. In this workshop, you will be able to design a perfect smile for any patient using the aesthetic guidelines as we just mentioned. Using these aesthetic guidelines and DSD templates, plus the manual ways that I will taught you, will allow you to show your patient the end result of your treatment plan. Also, you will be able to provide mock-ups for your technician to plan the treatment plan together. As we mentioned before, the informative triangle. You will be able also to judge any smile according to evidence-based dentistry. So let's start. Now let's go for the profile image. You choose insert, then shapes and line, and start to draw any line. You could control that line as you could see. Okay. We'll draw 3 lines. The E-plane, and the E-plane, if you remember, we said ideally should be 6 millimeter from the upper lip and 2 millimeter away from the lower lip. So this patient is ideal. Yet we couldn't have a prominent central incisor for such patient, a long central incisor. You know why? Because it has an acute nasolabial angle less than 90 degrees, as you could see. Another patient. In this patient, the nasolabial angle is less than 90 degrees, plus the patient E-plane lower lip touches the E-plane. So this patient have a convex profile. You couldn't have a long and a prominent central incisor teeth for such patient. The last example is this patient. This patient have a 90 degree nasolabial angle. Yet his lips touches the E plane, so we couldn't have a prominent central incisor for such a patient. And by the way, the cephalometric analysis for that patient, show us that he has a retruded mandible and chin deficiency. And as you know, in such patient, you couldn't have a prominent incisor. It will worsen his case.
Another way is that you could just copy and paste these elements from the DSD database element. You could take them as a whole group, like this. Control. Okay. And then right click, choose group, and choose group again. Then Control C, back to the photo, Control V. Now you have the whole element. You could move them, as you could see. But you couldn't calibrate them, possible to calibrate them that way. So you have to right click again, choose group, and ungroup this time. You start to move. Now you could move every single line along. This is the interpupillary line, the occlusal plane, and the midline. Okay, so we have two ways to insert shapes, lines, or to copy and paste them from the database element if you have them. And again, you could find them easily in our Facebook group, Tools Talk Small Design.
Now we'll start with the dental analysis. First thing you do, you measure the mesiodistal dimension of the central incisor and their length in the mouth of the patient and record that data. Then choose this ruler, Control C, Control V. Of course, you couldn't use them that way. By the way, this central incisor in the mouth of the patient was 8 millimeter. Okay, so as you see, it is 13 here. So we increase the length of the ruler until this central incisor width is 8 millimeter, like the patient's mouth. And to make sure that we calibrate this ruler right, you could also measure the length from the zenith point and the central incisor edge. It's 9.5, and the intubation mount is 9.5. So this ruler is calibrated. You understand how we calibrate the ruler now? You never take another ruler again. You just use the same ruler. You say Control C, Control V, and never to change its size again because it had been calibrated. Okay, there is two ways to draw our smile. We will assume that after the analysis, that this patient shown us an ideal E-plane and an ideal nasolabial angle. So we will just increase the length of this tooth from 9.5 to 10.5. I'm sorry if this patient have convex profile, not ideal profile, so we couldn't increase the length to 11.5, just 10.5. So we choose insert, shapes, line, and we take line here at 10.5. Okay, you remove the ruler, then you start to use insert, shapes, focus. This time we'll choose insert shapes curve, not lines, curve. And this is supposed to be the thinnest point. It is, as we said, 1 millimeter distal to the tooth mesiodistal dimension. So this is the middle mesiodistal dimension, and this is 1 millimeter distally, and that is the length 10.5. Okay. I click, left click on the mouse, and follow the anatomy of the tooth, because this tooth, after the analysis, we will go for gingivectomy on. So the incisor anatomy will be the same, but with a little gingivectomy, as you could see. Now we finished. Mark it. I don't like that point, that side of the tooth. We could right-click the tooth and choose Edit Point. By this point, I could edit and move the points again. So another order we take today, right-click, Edit Points. Okay, perfect. Okay. Then we will go for outline, right click, choose outline, and choose, or sorry, fill. First fill, no fill. Okay, we will go for no fill at first. Another way is to go for the DSD database element and choose we will choose the 80 ideal proportion. Okay, You move, if you enlarge this rectangular, it will take any shape and you will lose the benefits of it. So, Control Z, you should focus, you should press Control and Shift, Control and Shift before any change in the size of it. By that way, it will enlarge, but keeping the proportion, the 80 proportion. So, we need to decrease it. Again. That's just need to increase it a little bit. Control Shift. Control Shift. Here it is. Finally, as you could see, it is the same zenith point as the manual way. Then I'll go for the database element again and choose the tooth, which is here the right central incisor. And again, you should press Control Shift. If I don't press Control Shift, it will take any shape, so no use of it. Control Z, Control Shift. Oh, sorry. Okay, Control Shift. Okay. And then move it with the center. By that way, this border should be with this rectangle, unless the ratio is not 80%. But 85 is also acceptable. Okay, then we delete the triangle. You could do it by the manual way, okay, or as I draw it. Insert, shapes, curve, and start to draw your point, or by the database element. Okay. If you want to check the smile arc, if you remember, you will find it in the database element here, as you could see. Then you could take it as a group, and then right click, group, ungroup, as I taught you before. We want to check just the small r, Control Shift. This line, as I said, should be parallel to the lower border. So that's the lower. Should be parallel to the border of lower lip, sorry. So make sure that this line is parallel to the lower lip border. Then we move it to the two. The other side, same thing. We calibrate it to be parallel to the lower lip border. The problem here is that the canine, in such case, has to be intruded at least 3 millimeters. You could do it by reduction to cusp tip and make a gingivectomy here, or by orthodontic treatment. Now we know how we calibrate and design the smile extraorally and intraorally. Let's fill these teeth to take the shape of the proposed smile. There's two ways. Either by right click here and choose right click, choose fill, to choose picture fill. I have some templates here called A2, A1, A3, then insert, give it the shape of the teeth. Then another way, right click, and you should remove the outline now. No outline. Okay. Also, by picture format, you could change the brightness to change the shade. Here's the brightness. If you make it 25, it will increase it. So it's too wide, you could decrease it. Or increase. So we will change the shade by changing the brightness of that image. Okay. Another way If you are using the DSD templates, you choose the same tools template. If you choose this outline form, you have to choose this tool. Then, as I said before, you should use Control Shift. Otherwise, you will distort the shape of it. Okay? Control Shift before changing the size. And move it until it follows your design exactly. Follow my design exactly now. Then you choose the outline again. Outline, no, outline. And you do this for all other teeth.
I'll show some of my cases. As you can see, the planning of that smile shows that this patient needs gingivectomy. The pose and the leather. This year, many years ago. That's why it doesn't follow the smile arc. It's a traditional way. But this teeth, I use a new concept. This you could see a better smile. Even after I have finished it. And if you remember the static guidelines, they said that 1 millimeter or 2 millimeter difference in the gingival could be accepted, especially the case follows the smile arc and the proportions between the width and length are ideal, but I couldn't accept it. So I changed it, as you could see, a perfect smile. I could show you the planning of this case. I didn't finish this case yet, but I planned for it. It's an orthodontic case, and as you could see, there's a little bit skewing in the lower, but the midline is right. After I have measured these teeth, I find that it's 8 millimeter and the length is 8 millimeter. So of course we need to increase the length of it. But this patient has a convex profile, so we couldn't increase it to 12 and a half. It will be just to 11, and it will be just for 10 and a half. And that is the photo that I will show the patient next visit. I think she will be very happy. Let's analyze Regina's smile. I didn't know the exact length of her teeth. Because if you want to judge a smile and don't know the exact length of the patient's teeth, you assume that the mesiodistal dimension of post-central incisor are 16. So I calibrate this ruler to 16 and I find that the length is 10 and a half. If this central incisor width is 8. So it follows the 85% ratio. Also, I get the golden proportion from here. I check the golden proportion, I take it, copy, and paste. Then I found the relation between the center and the knife following the golden proportion. Of course, I couldn't use shoe analysis because shoe analysis need the full mesodistal length, mesodistal width of the canine, and the photo didn't show you that. Also, it follows the lower lip border, so we couldn't say that this is an ugly smile. So where's the problem? I think the problem because in this character, makeup destroy her look. It's the same teeth, by the way, but here's perfect. So it's not only the dentist job and her dentist. We all are harsh against the dentist. He done tremendous work. Follow all the guidelines. But that's a problem with all smile. You couldn't make a poor character homeless with a solid smile. An actor should take that in consideration.
You will find all these DSD elements at this group Two Stock Smile Design group on Facebook. At the end of this session, Smile Design High Performance Planning Workshop, I'd like to thank Dr Omar. He helped me a lot in this interactive sessions and how to plan for them. He taught me that the secret of success is to have no secret at all. He could help you too. They host these interactive sessions through Instagram page, post Torco. Watch for their bio, and you too could be a part of these sessions.